Hello, welcome. Sorry, we're starting a bit late. I've had some technology issues. I am delighted to tell you all about our caring context study in five Native communities. Just letting you know, I'm having a few technical problems, so hopefully you'll all hearing me okay and we'll be fine with the process, but please somebody, wave at me or raise your hand or something if you're having trouble hearing me. Okay, so we're going to talk today about CARE, which is our study of caring context that we did with partners from Native communities across the United States. Suicide prevention has really been a big issue in Native communities. The historically, as all of you know, historical events have really negatively impacted the indigenous peoples of North America, and that with colonization, genocide, and essentially the attempted sort of destruction of the native culture that has really had major impacts on the people's experience of their relationships, their connection across generations, and this sort of cascade of colonization effects has led to social isolation of people, and it's contributed to suicidality among members of the community. So what we did was I was working with Partnerships for Native Health, which was at the University of Washington, now affiliated with Washington State University. And they are a organization that partners between academics who can apply for grants, get funding, kind of play the whole NIH game. They understand how all of that works and can get funding, partnering with communities who have usually medical concerns that such as kidney problems, stroke, heart, etc. And they've done many extensive studies to improve these outcomes by conducting clinical trial research. One of the things that was partnerships was hearing about was increased concern about suicide prevention from the communities, and they usually try to set up the research to match the concerns of the community. And so they came to me to say, hey, could we work together to develop some suicide prevention work? So we did this in multiple stages. So we did some community engagement work to figure out what intervention would we do, chose it and applied for funding, culturally adapted the intervention, which is caring context. We'll talk about that. Conducted a clinical trial, and we also evaluated the cultural adaptation. And that's the things that I'll tell you about today. So when we did the community engagement, we went to 4 different Native communities, myself, in partnership with Abigail Echohawk and Mike McDonnell, to talk about what would the possibilities be of interventions that are available for suicide prevention at that time, which was about 2013, 2014, that we might try. And we talked to them about effective interventions that were available, that were designed or tested in American Indian and Alaska Native communities. And we also told them about other interventions like CAMS, DBT, and other interventions that were available at the time that were effective in communities outside of American Indian, Alaska Native areas that they might want to take on. We sort of did a tour, got some small funding from ITHS at the University of Washington, for which we're very grateful, funded our travel so that we could go to all of these places, talk to them, and in the end, we decided on caring context. 2 main reasons. One is a very strength-based, designed to increase a sense of connection, whereas some of the others are kind of more deficit-based. And it's also just plain feasible, both feasible for the communities to implement if the evidence supported it, but also feasible to do in multiple communities at once. And because suicide attempts are a low base rate, I mean, they seem awfully high to us, but relative to being able to run a study, you need a lot of participants for a study, and therefore we needed to be able to work with multiple communities. So we needed an intervention that everybody felt that they could sign on with. So let's talk a little bit about what caring context is. So the original idea of caring contacts was a strategy for uh, um, connecting with people who are at a dark point in their life and maintaining contact over time. So it was devised by Jerome Motto, who had felt during his work, he was a soldier overseas during World War II, that he really benefited from letters from a pen pal from his community back home, and really felt like when he came back from the war and was working in a psychiatric hospital in San Francisco, that that maybe there's a parallel here in terms of the isolation that folks were feeling. And so he designed this intervention called Caring Contacts, where they sent letters to patients who were not in treatment 30 days after inpatient discharge. So this intervention was designed and got started in the late 60s, ran into the early 70s. The trial that they ran published the initial paper in 1976. At that time, that usually meant that they had dropped out of care, not that they couldn't find care, given the way that health services were in the United States at that time. So here are some sample letters. They've got scratch outs because these are copies of draft letters that were sent. So, for instance, just a brief line to let you know that we hope that things are well with you. If you, this is just a note to assure you of our continuing interest in how you are getting along. We realize receiving a letter periodically expressing our interest in how things are going may seem a bit routine. However, we are interested in you and how you're doing. We hope that our brief notes are one way to express this. So the idea is they are expressions of care and support without making any demands. Motto in the original study, he really felt that was one of the most critical things, was that these letters would come not when a person was necessarily expecting them, not because the person reached out for help, not because the person was in distress, just because somebody remembered that they still existed and expressed care and concern for them. In the original study, they excluded the people who were in treatment, and they randomized the folks who were not in treatment 30 days after discharge into those who received the contact and those who did not. So this is kind of why you randomize, is that, of course, it looks like the treatment folks did the worst. This is sort of how long people went before they died by suicide. And so you can see people were more likely to die sooner in the treatment condition. That's probably more severe. It was not randomized. Only the contact was randomized. And there was a significant difference in the first two. Nothing after that. Then in Australia, in the early 2000s, a psychiatrist who was worked with toxicologists in a region of Australia designed this as his dissertation. So you see this little card here. It's been a while since you were here at the Newcastle Mater Hospital. We hope your things are well for you. If you wish to drop us a note, we'd be happy to hear from you. Best wishes, Dr. Dawson and Dr. White. All printed, all the same. Every single card looked exactly the same. They were called postcards, but they were in envelopes for privacy. So what they found is that randomizing half the patients to get these cards versus not, you can see over 5 years a really significant cumulative difference in the number of psychiatric hospital admissions, and this is the difference in medical self-poisonings. So this was really exciting, and that's really what got me interested in this work. This study was followed up by a colleague of Dr. Carter's in Iran, who did a study with 2,000 suicidal individuals in Iran. They did it with greeting cards, and you can see they included quotes from the Quran or poems in the cards with floral pictures on the front of them. They also found a difference in suicide attempts. In this case, this is self-report of a suicide attempt. They also found a difference in whether the person reported any suicidal ideation, and this was sustained at a 12-month, so a year after the card stopped coming. And that led us to our study. We did a study with the Army and the Marine Corps. We moved to a text message model. So you can see some examples of the kind of text messages where this top message is the initial message, and you could see the responses and then the responses back. So like Motto, we used individualized responses. So we had set messages that were all the same for everybody that went out on a set schedule that was pre-programmed using a web app. But when they replied, we responded individually. If they were in distress, which was a shockingly small number, because you're not catching somebody when they're particularly distressed, you're just catching them because it's like Wednesday or something. So we would usually respond with a validating message, followed by ways of reconnecting them to services. The DoD really did not want us to kind of create our own treatment relationship, so we were always reconnecting them back to existing services. So we also found an effect. We did not an effect in the things that we had expected, which was current ideation and whether they had a suicide risk incident, like went back to the hospital or the emergency room. But we did find the similar effects to the Iranian study, which is a reduction in worst suicidal ideation and a reduction in the risk of a suicide attempt during follow-up. If you look across studies, Nancy Scott and colleagues did a systematic review and meta-analysis, and what they found is across studies that were available at that time when they published a few years ago, it was for suicide attempts at 1 year. Okay, so that's how we got to this study. Next step, step 3, having kind of gone out to the sites, made a selection of what we did. We applied for funding. That took a couple of years. And then we began our colonization. So we were working with Native communities in 4 states. We also had a community advisory board, and we conducted research and revised. This revision what included changing the messages, changing some of our assessments sense to each community. So we did not go into a community until they had approved all these aspects of our research. So 55 people through focus groups and 19 people through key informant interviews. We did key informant interviews with tribal leaders or other people where having the part of the focus group might inhibit the focus group. The things that we found were things that you see in other studies around caring contacts, and also things you might see. They really wanted us to incorporate local language, have maybe to have tracks based on people's interests. I can come back to that if people have questions about that. That's something we knew from previous work wasn't working very well, so we didn't end up doing that. They wanted us to include some spiritual content, to regularly kind of send the website that explained who we were, etc. They really wanted us to avoid being too generic, which we'll come back to because this may be an important point. They definitely would be cheerful, but not too cheerful, but positive. Oops. And be careful of things like triggers. And what they really wanted was for it to be on Facebook Messenger, since that's the main communication tool that folks use in these communities. But we tried could not find an highly confidential way to do this because Facebook is, really designed to pair people who are attached in some way. And if we send messages to all the suicidal people in a community, they will then all be paired with each other. And with the RB, we decided that wasn't possible. We talked to Facebook, we did everything we could, but we have so far struck out on that. They really wanted to be sure that cultural values of humility, leadership, helping others were reflected in the messages, and that we should use local stories and metaphors, be connected to the culture. We definitely wanted to talk about the timing, like how many messages, how often should the messages. They felt that 11 messages, which is what we did in our military study, was not enough. And so they wanted extra messages during periods when there tends to be more suicides. They wanted messages tied to the seasons, tied to tough times that people are experiencing in these communities. They also felt that we should send them more often at the beginning. So every week for the first 6 weeks, then every other week, and then monthly, which is also much more frequently than we sent them in the previous work. So these are just some examples of some of the general caring context that we came up with. So then after we came up with them, we worked with each so we hired our staff from each community. So the people who were sending the messages, recruiting people, doing all the assessments, they were all members of the community, or if not an actual member of the tribal member, they lived and worked in the area. And we had them each develop messages sort of according to these cultural themes and guidelines that we developed from the adaptation. So you can see some examples of that. Here are some examples of the seasonal messages that were developed. And you can see that some of them are a little bit longer. The leaves are gone and the days are short. This can be a hard time for a lot of people. Just know I'm thinking of you and sending positive vibes your way. If you need to talk to anyone, feel free to send me a text or call. One of the things that was not possible in these communities was for us to function in any way like a crisis line. All of the from the study and what they had in the community was, everybody working at most on a full-time schedule. Some of our staff were part-time. So we were clear with them up front, we are not a crisis line. If you respond to us, we will respond to you during our work hours. And like any other service on the reservation or in the community, we have certain hours and we're available then. And then we get everybody emergency information and who they should call if that wasn't, if they had needed help when we weren't available. They also really wanted us to let people know about events in the community and let them know they were welcome to those events. And so here's some examples that reflected that. We tried not to be more and that this is a place that you can come if you want to. In the end, we actually didn't end up sending very many of these messages because of COVID. And I'll talk about that in a bit. And then here are the birthday greetings. That's something we had sent in the military. They also wanted holiday greetings. So you can see some examples of holiday greetings that we sent. The other things that we changed was that because the highest risk period in Native communities in the United States was between 18 and 34. There was a risk group also 15 and up, but there were a lot more youth programs happening in Native communities, so we were really going to focus on adults. But they really wanted us to raise the upper limit, so we went 18 and over, not 18 to 34 in the end, based on their feedback. We also did not, they did want us again to use Facebook Messenger. And we did end up using greeting cards or email if the person didn't have a phone, didn't have text or didn't want to text. So they also really wanted us to um, uh, think about what would we want to do in terms of how we ask our baseline assessments. They definitely did wanted us to have a control group. And so the control group that we ended up developing with them was something that was best available care. And we made sure everybody got it. So everybody who did the baseline interview asked assessment questions. Then each of the interviewers spent some time with the individual reviewing what resources they needed, what resources they had, which they had actually figured out from the interview for the most part, and gave them like a resource card where the resources that were specifically useful to them were circled, and let them know that they could call us back anytime if they needed additional resources, and that we were available for that throughout the year. And so that meant that everybody, we couldn't really have much control for what resources available. That people did not always have access to something like an inpatient unit without having to drive 5 hours. They're just very limited resources. So we really tried very hard to meet them where they were and be sure that everybody had more than they started with if they chose to come into the study. So then we did our trial. So we recruited suicidal individuals who were identified by community healthcare providers, like we had signs up at laundries. The site coordinator or our interviewer, the baseline interview, they were randomized to receive the messages or not. If they were scheduled to receive the messages, they got the 25 messages. Best available care was, as I just described it, was available both. And then we assessed them again at 12 months and 18 months. We did not do additional assessment during the time because this intervention is very small, and we didn't want other contact from doing further assessments to potentially reduce the effect size by having this contact with both the control and the experimental thugs. So then we had COVID. So COVID hit when we were really just trying to kind of get some traction with recruitment, and we had to pivot this to becoming an entirely virtual study, almost entirely conducted on cell phones, because that was what our that is available. Our research team adults. We've had people who lost siblings. We had who something happened to their take grandchildren. It's a really hard time is um, struggling. Hearing a lot of these tragic stories with suicidal participants. If I did this again, I do not think I would listen to um, these do um, limit the story to some of the most effective, and not have them like listen to the story of every single attempt that the person had made in the started in April of 2022, in August of 2023. We recruited 709 participants across what ended up being 5 communities. Sorry, I just thought there was a chat. Um, okay, let me do this. Let's see if I turn my video off. Is that better? That's better now. So after the that
Hi, Kate. It looks like you have disappeared. One thing I'm going to suggest is if I share your slides so that your bandwidth's not trying to do that.
Okay.
And it looks like you're on so you could just tell me when to
Oh,
um, click to the next slide. Let's see, I'm trying to get to where you are.
how is that?
It's good. And I will share my
Are you
screen.
hearing me better now? Or is this just as bad?
I'm hearing you now. I think it still
Okay.
comes in and out a little bit. Um, but
I'll
this is certainly clearer than it was a second ago.
apologize for that. Okay, thank you. I'll let you know when to shift.
Okay.
Uh, so, so what I was saying was that we were evaluating our culturations. So we considered an outcome for each of our adaptations that I was telling you about. So we found by interviewing people after they completed um, the year of messages that they did not recommend very many changes to the messages. They felt that the quantity, frequency, content was pretty right on. We ended up recruiting more than wait a minute, nearly half of our sample was older than 34. So they were absolutely right in saying that we should include older people, and that they encouraged us to use email and postal mail, and a lot of people to get the messages that way. So that was also a good call. Um, they we ended up using a lot of the types of recruitment that they recommended, and that went that was where we got a lot of our participants. Next slide. Uh, we made some changes to the instruments to include locally informed methods of suicide. When we asked about methods in our standard general population measure, we didn't include some measures, jumping in front of a moving vehicle, going out in extreme weather. They told probably needed to include that, and you could see that that was absolutely right. And they gave us, feedback about how we needed to kind of do our participant experience with the initial interview and offering the resources. And again, they found this a particularly positive experience. Next slide. So here are the results of our trial. Like I said, we recruited 709 folks. We struggled more with follow-up. Again, we were in COVID. Our team was absolutely heroic in doing everything it could follow up. We only were next slide. Julianne, oh, there we go. So here's our sample. So we were 64% female, 35% male, small percent other. Folks were spread out across the adult years, as you can see, and most people were living on a reservation for this study. Not all of the communities were entirely reservation based, so you can see about 31% were not. Next slide. The feedback that we got is is not only not necessarily a risk, uh, but it also can be a real benefit. Next slide. The Messages were very popular. You can see these are some questions that we made into a scale about how well the messages were helpful, and you could see most people were scoring all the way at the top of that scale. Next slide. Here are some qualitative responses that people just describing their experience. You could see that people really liked the messages, and yeah, so I think that I won't read all of that to you. They really did feel like they appreciated that they got to know the person who sent them the messages ahead of time. They liked that they were a member of their community. At the end of the caring contacts, we asked about, kind of how much those messages affected what else they did, and they really felt that it did encourage them to seek help elsewhere and be more confident in their ability to cope, and that they felt that participating in the study was a positive experience. Next slide. But no effect whatsoever of contacts. So this was, you could see these numbers are almost exactly alike. So people had definitely reduced the amount of suicidal ideation and the risk of suicide attempt, but not any more in the control than the experimental group. Next slide. What we did find was our secondary aim in this study was to show the impact of social connectedness, which we thought would go up with caring contacts, but there was no difference in caring contacts. So this data is adjusted for treatment assignment. But what you can see is these green dots indicate a significant effect of a change in social connectedness on whether somebody had the level of suicidal thoughts and feelings they had at follow-up. So in other words, at baseline, we asked you about these different measures of social connectedness. We also asked you about that at 12 months. We looked at the difference in that and did your social connectedness go up? And we found that for people whose social connectedness went up, their suicidal ideation went down. Next slide. We also found for 3 of our social connection measures, perceived rejection, loneliness, and perceived burdensomeness, that a reduction in an increase in social connectedness resulted in a reduced risk of suicide attempt during follow-up. Caring contacts, effective intervention in this circumstance, connectedness is clearly important and clearly where we need to go next. Next slide. So our study had a number of limitations. The biggest one was pandemic. Um, During this time, it's a really hectic and difficult time. The a pretty to do the research that way. It was not designed to, it was designed that it could be done that way, but we really hoped it wouldn't have had to be. It likely slowed down both our recruitment and our follow-up. And there may be unique circumstances of the pandemic that affected the results that might not generalize in other situations without a pandemic. Next slide. There may have be issues. There's pros and cons of employing community members as research staff in a suicide-related trial. It was really challenging for our staff to be exposed to traumatic stressors and losses during this time. They were very much affected by hearing the stories of their fellow tribal members experiencing suicidality. The team worked extremely hard to kind of provide support. So if staff needed a break, they couldn't. We tried to provide coverage from another site, and opportunities for rest and self-care to help people stick with it all the way through. Next slide. We unfortunately were not able to follow up with 36% of the participants, so the results may not fully represent the whole sample of 709 people. The suicide attempts were retrospectively reported, so maybe somebody failed to report one or misreported because they misremembered. Social connection measures were all self-report surveys, like I said, mostly completed on the phone. And we only did the qualitative interviews with the people who received caring contacts, so we don't know as much as I think in retrospect we wish we did about the people in the control condition. Next slide. So in conclusion, this is the largest clinical trial of suicide prevention in Native communities, and it was conducted with culturally adapted intervention and study methods. There was suicide-related outcomes in this study. Like we tried a number of sensitivity analyses to see if there was explanations for why it might be that there was no difference, and it just seems there was no difference. However, like I said, improvements in social connection were important. And we definitely found that people really like the caring contacts. And so it may be that the control group, which is kind of sad, but in that it wasn't bigger than it was. Just having an initial interview and offering resources. But those resources were tailored. I really do think this impact of having a empathic person from their own community listen to their story in a non-reactive manner. We were not quick to to hospitalize somebody as many other people they would talk to were, and that really allowed them to tell the story without kind of dealing with a sort of frightened or distressed person, and that may have had a use themselves. Next slide. Next, oh yeah, thank you. So our next steps, we're sharing our results with our partner communities over the next year. We're considering other interventions to increase social connection, including potentially this kind of empathic interview. Is that something that, because that would be a pretty pragmatic thing for people to do. And we want to think about other interventions that sustain collaborative relationships and kind of continue to kind of nurture and support social connections, since that did have a significant effect in this study. Next slide. And that's it. And I would be happy to take comments or questions that folks have. Oh yeah, my contact information, sure. Uh, yeah, please email, that'd be great. Yeah, yeah, for us.
Hi, Kate. Hope you can hear me okay. No, I really enjoyed that.
Yeah.
Thank you. First, congratulations to you and the team. Huge effort. It's a complex trial in a very important community. So well done to everyone for getting it over the line. I've got a couple of questions if that's okay. The first question is, I think from understanding the methodology, It was a type of decentralized approach where the care and contacts came from the trial team rather than from any health service in those five communities. I wondered,
Correct.
from that logistical experience that you've had, how do you think that could translate into, for example, primary healthcare services across, one, two, three, four states, for example? And the second question around the outcome, I wonder, you mentioned that the enhanced usual care could have been a contributory factor to the control group having similar scores. I also wonder how much has anything from the qualitative work come out of the cultural adaptation work that you think could be potentially optimized or improved, or that could have, in an unintended, consequential way, could have impacted on the intervention itself. Thank you.
Yeah, I think that the in terms of healthcare, we're doing a lot of work now. There's a number of different colleagues that we're working with, kind of in the healthcare environment, trying to figure out the way to do this. One thing we're seeing is really an impact is not having the person who's providing current active care sending the messages. It just gets weird, essentially, if you're having one set of contact and the next day a message comes and the what is, especially if you pre-program those messages for practicality purposes, it's really, really challenging for to figure out how to kind of make those sync. So it's, I think having another person who's doing that, somebody who, for instance, provides this for everybody in the primary care clinic, right? Rather than, I do wonder if the primary care doctors have infrequent contact enough that they could author them, because it's not like it's going to probably conflict that often with anything that they might be doing. So that's something I think worth finding out. And it's just there would need to be a lot of assistance and support for them because they are, well, you know better than me, way busy, and it would be very, could be very logistically challenging for them if they didn't have a MA or somebody dedicated to making sure that messages got responded to, etc. I think one thing we are wondering about is whether adding a lot of these additional theme messages and events and all of this may actually not be helping. And we're sort of seeing this across a couple of studies where they haven't had results, and those studies have had longer or more complicated messages. We're wondering about, is there some cognitive burden to that? Is there something about the really simple message that is actually more compelling to the person receiving it than something more some more complicated thing? And if they respond, then they get a very individualized response, right? Where the person just answers whatever they said. So I'm a little bit inclined to test that out in some of our future work. Um, Uh, I want just to clarify, Finn, it's not the first clinical trial in suicide prevention. It's the first that's at this scale, 700 participants, multiple sites. There have been other smaller sites. Therese Laframboise did a trial of a school-based intervention. There have been smaller studies of things like distributing gun safes. So there are other smaller suicide prevention trials. This is just this was at the time anyway the biggest. I don't think somebody's done something that big since. The White Mountain Apache folks might have some trials that would start to approach that, but uh so we sent the messages, Jane, through a web app that doesn't exist anymore. Where that startup company has kind of gone in a different direction. But there is a company called Mozio, what I stuck it in the chat here, who does do this, and you can um, uh, reach out to them, and they have a program for setting this up and being able to route responses back to you. We've collaborated with them to try to kind of get all the best quality sort of functionality that we've learned you need to be able to do these messages well. One of the other areas I'm interested in is, are there ways from a healthcare point of view that we could embed it inside of an EHR system? Because I think that for a healthcare environment, that would be better. So you wouldn't having to be tracking things in essentially two separate locations. Betsy, is there something um, uh, well, yeah, it's a really excellent question, Betsy. I think that there really I think there is a lot of options and things that need to be tried. I think that um we did recommend folks some of the services that we recommended when we did our resource review included the traditional services that were available in their community, including smudges, sweats, etc. I think that we don't know any people just have not done uh the work to really understand which are the best interventions in this community. Um, Doing travel research is hard. It is hard because the communities are very wary for a very good reason about working with general population academics on research. There's a lot of extra steps you have to go through in order to get lots of approvals. We had 13 boards across our 5 communities who monitored our study. Well, it's 12, it was like 11 plus NIMH DSMB plus our own IRB. So it was really quite a lot of regulatory process. I think that is really good on the one hand in terms of protecting the tribal members from problematic research. And it does mean that there's not as much research probably as there could be. And that's just a kind of pros and cons. Other questions? Okay, well, I know how important it is to get a few minutes back into your day. So we'll go ahead and end it here. Oh, yes, thank you, Julianne. Please do see our website for if you'd like to know more about caring contacts or you want advice on how to implement caring contacts. We've built a very nice that and how to work with the Mosio platform. So please pursue that if you're interested or just reach out to us. Thank you so much, and we'll see you next month. Apologize again for my tech issues.